everybody, I'm Haddas from the University of Rochester Medical Center.
I'm Tobias Mattei from St. Louis University, Chief of Spine Surgery and Associate Professor of Neurosurgery.
And hi, I'm Bill LaVelle. I am from Syracuse, New York at the SUNY Upstate Medical Center, the Upstate Bone and Joint Center, and I'm the Spine Fellowship Director.
Good, and today we'll talk about risk fall of cervical myelopathy patients. So let me ask you, Tobias, a question first of all. What are the risks for risk for fall for cervical myelopathy patients? Can you characterize those patients, type of patients?
So cervical spondylotic myelopathy is it's a common degenerative conditions that we see and secondary to spinal stenosis, which is usually multifactorial, disc protrusion plus ligamentum flavum hypertrophy. And the symptoms of cervical myelopathy are multifaceted, but gait impairment is an important one. We know impairment of fine motor coordination is also a meaningful one. And one of the important things is that I think we cannot overstate the importance of assessment of falls in this patient. There was a very interesting study that I reviewed, and it was a series of 350 patients that were submitted to surgery. And the authors evaluated how many of those patients reported at least one fall in the year preceding the surgery. And it was about 50% of the patients. And from those who had fall, 1/3 had worsening of neurological deficits. So by the time we see the patients in the clinic and get the MRI and indicate surgery, those patients already had worsening of neurological deficits because of falls that could have been prevented and impacted the long-term outcome.
Yeah, thank you. So Bill, let me ask you why this is so important to detect this balance disorders in these patients.
Well, one of the main causes of injury is just that, it's falls. It isn't just the fact that they fall. When patients fall, they get secondary injuries. So you're having a discussion here with a neurosurgeon and orthopedic surgeon as well. While both of us principally do spine surgery now, if someone falls, they can strike their head and have a head injury and a hematoma. If you fall, particularly in an at-risk population with osteoporosis, you can sustain fractures of fragility in your wrist or in your hip. And these have proven outcomes with regards to substantial morbidity and even mortality. A hip fracture is certainly a risk factor for a myelopathy patient with falls. And that's not even withstanding what you just heard about, which is that patients who have neurologic disorders such as myelopathy, after their fall, they can actually worsen their myelopathy and worsen their cervical dysfunction.
Not to mention how those other orthopedic injuries can affect the recovery from any surgical intervention for myelopathy. I mean, you have a patient with spondylotic myelopathy who needs surgery and they have a hip fracture. Your surgery is going to be meaningfully delayed, and even their recovery is going to be significantly affected by the other injuries.
Yeah, and on top of that, don't forget the post-falling syndrome. So after a patient is falling, they feel insecure to walk after by themselves. They become dependent. A lot of money involved in that, and those guys just don't want to move anymore. So let me ask you one more question, Tobias. So how do you assess balance disorder for these patients in your clinic right these days?
So our assessment, it's part of our clinical assessment. We do a history of their symptoms. We do a physical examination, and we use standard tests like Romberg, and we evaluate gait. But I can tell you that, I mean, our assessment in the clinic for these patients is mainly directed to identify what we call clinical radiological correlation and indicate surgery. And that's why I still see, as much as we try to be sensitive for those patients with, incipient myelopathy or those initial symptoms, especially in patients that may not need surgery up front, when you have a team and you have the option of having an emotional lab or even a functional capacity evaluation with a more detailed sort of test like the grip test, which has been shown to correlate with the MGOA very well, that's definitely something that enhances the quality of care.
Yeah, let's face it. I mean, office hours are very busy. We're asked more and more to see more and more patients. The baby boomers are getting to an age where this is a real problem. And no matter how altruistic you are, scientifically, it's very difficult to screen truly functional balance and at-risk patients in a very short, discrete office visit. And it really highlights that we need something more.
Yeah. So besides that, can you just talk about more limitations besides the timing, like of the testing, like of balance?
Well, again, they're tests that are classically described, like you heard about a Romberg test where you ask someone to stand and see literally whether they fall over, or even one of the ones that I use a lot in my office hours, which is that to try to have a patient heel to toe walk. We use it as a thresholding tool, but if you think about it, older patients have other reasons other than myelopathy where things like heel to toe testing may be affected. And that just really highlights the need to try to delineate that further. On top of that, I mean, to be honest with you, even screening tests for myelopathy, like things like a Hoffman's or a reflex in their hand, if a patient is really dedicated at the time of the visit, they can make up to some degree for their coordination and balance issues at that time, but that doesn't really herald what they are like when they're doing their day-to-day activities. So, I mean, we really are very limited by our discrete exams. And on top of that, when you look at patients who have myelopathy, right, we spend a lot of time from a research standpoint trying to understand where that sweet spot is for intervention. And, qualitatively, if we don't get them early, if they have substantial underlying dysfunction, it's harder to get it back. If someone is really involved with their myelopathy and they have a late surgery, they may not get worse, but certainly their quality of life is already affected, that they may still be at risk of falls and they may still have substantial dysfunction. So assessment tools to figure that out earlier are critical.
Yeah. And I can present a very interesting scenario in which the gait impairment affects my decision making. So you have those patients that they have, for example, moderate stenosis, they have no CSF around the spinal cord, but no clear T2 hyperintensity in the spinal cord. And they don't complain that much about impairment of motor coordination, but either because of the myelopathy or even because of some superimposed diabetic neuropathy on top, you do just a subjective evaluation of their gait and ask them to walk, and they seem pretty unstable, and the family confirms that. That's the patient that is a quite higher risk than even those patients with mild myelopathy to present to the ED with a central cord, because according to the family, they have been falling 3 times a week. So those are the patients that I say, I mean, I don't talk about prophylactic surgery, but in your case, you're at such high risk of fall that I think we should be proactive in this scenario.
Right. I think that's a better word, proactive rather than prophylactic, because again, the dysfunction that these people have and the risks that they inherit, and there's simply going to be more of them as the population ages, is critical to the individual and also to society in general. I mean, more people with disabilities is just terrible.
Yeah. So you mentioned radiographic functional testing. What about surveys and questionnaires? Like, how much do you guys use in those questionnaires, and how much you rely on them to detect myelopathy or risk for falls?
Well, the truth of the matter is we do it more now than we did in the past, but we probably don't do it enough right now. Most of the questionnaires that we ask really try to look at whatever disease state is impacting a person's overall life. So, total health functional questionnaires we use. They don't really screen well for myelopathy. We also use questionnaires and screening tools to assess cervical disability in general. They probably don't do a good job in screening for myelopathy. So I'm not sure that there's really a high adoption rate for surgeons to use screening tools for myelopathy right now, and perhaps there should be.
Yeah, and I agree with you that even when we use the questionnaires and quality of life or the MGOA, which is specific for myelopathy, I don't remember a case where I was undecided about indicating or not surgery, and I went back and said, hey, this patient crossed the threshold in terms of MGOA from mild to moderate, I'm going to indicate surgery. I mean, if there's a big discrepancy and I say, hey, let me redo the physical examination, let me see, because the questionnaire shows me something different, let me ask the family about other factors. But at least in my context, we ended up using more for research purposes and for evaluation of our post-operative outcomes, rather than to influence our decision-making in terms of surgical indication.
Right. So more and more, I mean, currently questionnaires are used more to objectify the decisions that we already make than it is to create a screening tool that would identify these patients earlier. And so maybe there's room for us to try to come up with something, even outside our office. You know, patients, while they see us, they certainly see their primary care doctors more than they see us, and with, you know, a risk of, you know, over 2 million people having falls such as this, perhaps it's better placed there.
Yeah, so we're working on that. I mean, you know, working with both of you guys, we try and develop some tools that will happen outside the clinics. Like if it's a motion lab, if it's a wearables, if it's actually using your phone to detect how you move, and try to give you guys more detailed information or nuance that you guys not necessarily can see in the clinic. I would like to mention a couple of those interesting papers I just read. One of them coming from Japan. They're actually using your phone for a grip and release test, and they found that actually for myelopathy patients, if you're doing in 10 seconds below 13 times, you actually have a severe risk for severe myelopathy. Above 16 is mild myelopathy, and over 20, you just basically are healthy. So these are just very simple tests that can be done in the office, in a PCP office, like you said. They can help you detect those stuffs. We're also working in the research components. We're also getting those time up and go, the tandem gait, like you mentioned. There's actually a triangle test that's just come up right now. Those myelopathy, see how much they can walk in the triangle. So working on the walk and the turns on the same time. We publish a lot of papers on gait on patients with myelopathy, and we know the base of support is wider. They actually tend to sway a lot more. You mentioned Romberg test that we actually do on these patients. We know these patients are swaying more. They're not efficient. The way you stand, the way they walk, and doing other activities. So here's my questions for you, because this is very nice and this is well done for research. How much do you guys see it implementing all these advanced tools and technology? If it's the video-based that I mentioned, EMG, PCP, like using your phone kind of testing, how much do you see this implement in your clinic, and if this can save you the time that you're mentioning?
I think it'll come more and more. I mean, I think it does a better job of quantifying the patient's myelopathy. And like I said, I think you'll see greater adoption of wearables for patients to ultimately be screened for it. I think what you'll see is over the next few years that it will become more and more part of routine clinical treatment of patients. I mean,
but one thing to highlight is that, I mean, if we look at practice, and we're talking about academics, not even to mention private practice, but it's a very small minority of centers where you have access to a motion lab or something similar to that. And sometimes we think that we need technology or widespread, but sometimes what we need is better organizational skills. So, I mean, if you develop a team with a physical therapist and an occupational therapy that can do a good functional capacity evaluation, and with time, and we see so many patients with cervical myelopathy, they can incorporate some of those tests, not probably the fancy ones with the video analysis of gait, but some of the most basic ones, and send us back that information. It would work the same way that I send a patient in the preoperative of a spinal stimulation for a neuropsych evaluation, and they come back with those results. So I think it can be implemented at a relatively low cost if you're able to integrate other professionals and let them do the job in terms of their skills and get their experience in terms of evaluating gait. And then as a clinician, I have their input plus the results of the MRI plus the history and the physical examination to put everything together.
Yeah, I think the other thing though is that with more data from devices like wearables, EMG, things like that, that we will probably refine what it is that is the thresholding and the identifying factor for myelopathy and the secondary component of myelopathy that leads to at-risk falls. You know, and we see it now. And from a healthcare screening standpoint, if you think about it, you know, we do more and more of it in healthcare in general. You know, we decide algorithmically from pools of populations to see whether, you know, does everyone get an EKG every year? Does everyone get a chest X-ray every year? It may be that everyone gets some form of myelopathy screening every year, and that may be just better done with a device than it is with a a series of questions, or we may find it requires both.
And in terms of bridging that translational gap between all the tools in research and all what we see in the papers, and they're very interesting, and our daily clinical practice, I think the key is user friendliness. Yeah. I mean, if you have something that your patient is able to carry an app on the iPhone and it detects those subtle movements with us quasi falls that they almost stumble, and you're able to have those triggers, and you come back and say, hey, you almost fell 5 times this week or something. Those are the things that we really need. So easy tools that can be incorporated without the patient or the clinic having to invest a significant amount of money in new devices or new technology.
Yeah, and there's a lot of technologies coming out, and I think one important thing we have to do is to standardize what we're going to do. Yeah. Right, like which test? I mean, do we want to focus on the wearables? Do we want to focus only on sending everybody a motion lab, although it's not always available to everybody? Using these apps, like you said, everybody have a phone these days, right? Can we actually use the apps to our favor? One more thing, like you mentioned, Tobias, is patients' compliances. When patients get some data right back, they feel they have to do better, right? Yeah. Or they make more aware. Because when you ask a patient, okay, how many times you fall, one of the questionnaires, they may or may not remember that they fall last week, right? But when we have the apps, or we have the watch, or the wearables on them, basically, they actually quantify, right? And can give you some objective information of how many times they did. It may help you guys to get a better decision of what to do with these guys.
Right, and more people are more engaged in their own healthcare, so.
And that helps with informed decision making, right? You may have a patient and they say, oh, I only fell once last month, and the family's there, so no, it was 3 times. Yeah. And then you see the app and say, hey, I mean, you only fell maybe 3 times, but you almost fell, you have those quasi-stumbling episodes 7 times last week. Yeah. So, you know, it definitely helps to have an objective measure so the patient can realize their actual situation and decide if they want to proceed with surgery.
Yeah. And one important thing to mention is that when we doing this functional testing in the clinic, patients somehow have the white coat effect. They try to perform better or perform worse in work counts, for instance. Or you send them home to a natural environment, right? And you're able to track what they're doing over there. This will provide more truly information on what's happening or how their balance is severe for these patients. So I think it's also something that's unique that I'm really excited to come up with in the next couple of years, basically. Good. Anything else you guys want to add?
No, I just think that, like you had said earlier, I think that the future holds a lot with regards to what we're going to learn about screening people for myelopathy.
Yeah, great. It was great. Thank you very much for your time, guys. We really enjoyed it.
Thank you. My pleasure.
Thank you.